So the new technologies advanced have new techniques like IRE, which is a reversible electroporation. The IRE is a new technology that destroys cancer tumor with short electrical pulse without thermal heat. The main advantage of IRE is that can be administered for tumors near critical parts of your body without damaging the healthy organ tissues. The data are gathering nicely, but we still don't have enough follow-up to know how effective are these techniques. HIFU, in the other hand, is a new technique mainly used for prostates, breasts, and other locations, less in the kidney disease because of the need of fixed organs. The kidney, as you know, moves with the breathing, so it doesn't allow for accurate and perfect targeting of the tumor. There are other technologies that's going to be coming in the future. I'm going to talk just about the histotripsy that uses sound waves, like kind of the lithotripsy, and is responsible of mechanical destruction of the tumor tissue. So all this are now being studied actively in all the centers to allow for gathering more data to be available in the future. So it's very interesting, this question, because now that since we have more survival with kidney cancer due to the evolution in the systemic treatment and all the stage 4, we start getting involved with the treatment of metastatic disease more and more. So the bone involvement is known to be very common and is being responsible for problems with mobility, especially when in all the bones around the hip are involved. So interventional radiology is now used in two ways, either for the stability of the bone. We use a technique like percutaneous screw fixation. So we just like place screws in the areas where there's bone support, and we inject some cement in the area where the tumor has destroyed the bone to help with the bone stability and the mobility of the patient. And in the second hand, for palliation of pain, we use cryoablation to destroy all the nerve around the area where the tumor is spreading. So we create what we call cryoneurolysis, and this allows for better control of the pain once the bone is involved. So IR is effective in treating like lesions in the spine. We do kyphoplasties, so we solidify the spine around the area where the bone metastasis. This allow for mechanical restoration of the spine, and this alone can help very well with the pain management for these patients. Sometimes we have to use cryo to destroy the nerves, which we call cryoneurolysis, or also inject some medications around the nerve roots to diminish the pains from different metastases in the spine. For kidney cancer, especially the stage 4 kidney cancer, there had been lots of advances that can benefit certain patients. It's very important to seek a second opinion to know if there is any new technology or any new procedure that can be performed. Technology's advances have improved ablation precision, allowing us to treat tumors with high accuracy and fewer side effects. New techniques, as I mentioned earlier, like IRE, irreversible extraporation, improved the destruction of tumors close to vital structure. There is also improvement in thermal monitoring that provide a safer and more effective treatments. And there are also new technologies that are designed to stimulate the patient's own immune system. And this is all to activate our system against the tumors. These are being studied to treat solid tumors by including the mediated cell death and neoantigenic reaction. One of the best that I've seen in the past 4 or 5 years, the best indication for IR procedure for metastatic disease is lung ablation. Lung disease is very common in the stage 4 kidney cancer. And lots of these lung lesions, as I mentioned before, they don't respond quite well to immunotherapy. And instead of increasing the dose of immunotherapy or changing the drugs, and when there are like fewer lesions, this can be completely controlled within ablation. In general, we use microwave to burn all these small lesions and achieve what we call M1 NED, non-evidence of disease. So we can render these patients again free of disease by just one procedure. We do lots of these lung ablations here because it allows the patients to stay without changing the systemic treatment, without increasing the dose, and it's very helpful for these patients. This is why it's important to discuss all the cases in DMT, which is the disease management team. So IR can mostly be used in areas where the tumor is small or localized. So we have the limit of the size. This is one of the limits. And we have the limit to the proximity to major organs. So for the heat-based technique, there is risk of injuries, but a good IR will make the difference once IR can be used versus other techniques. Most of our procedure are done as an outpatient procedure or same-day procedure. Rarely there is an overnight stay for pain management or the comfort of the patients. So it's minimal pain, as I mentioned. So return to work can be pretty quick within 1 or 2 days from the procedure. There is no scar tissue or there is no wound as we use percutaneous needle with band-aids disposed at the area of the puncture that can be removed the next day. So most of our procedures are really mini invasive with less than 5% complication risks.